Good afternoon. Welcome to Grand Rounds today. Remember to sign the attendance record and also to fill out and turn in the program evaluations, and also a reminder that we will not be having Grand Rounds for the next 2 weeks. Today I have the pleasure of reintroducing Dr. David Moore, epileptologist and neurologist. Dr. Moore attended medical school at the University of Iowa, then did his residency at the University of Wisconsin in neurology before moving on to Vanderbilt, where he did his epilepsy fellowship, and he now is a member of the neurology staff at the McFarland Clinic and at MGMC, and he has kindly accepted our invitation to update us on epilepsy classifications and anti-epileptic drugs. And please join me in welcoming Dr. Moore. Thanks.
Good afternoon. Unfortunately, this is one of these talks that's rather boring, so I'm sorry about that. In terms of conflicts of interest, I participate in multiple drug studies, some of which are anti-epileptic drug studies. Those would have been perampanel. Its brand name is Fycompa. Cannabidiol, which is not on the market, and I'm not going to talk about meds that are not currently on the market for a variety of different reasons. Breviracetam, I participated in it as a drug study, and several of the other drugs. I participate in drug studies for various drug companies. To start out this talk, here, slide. I have a couple of questions to ask the audience, and then seizure definitions, or epilepsy definitions, differential diagnosis for epilepsy, and this becomes a very important thing to talk about because when we see people having spells or events, the first thing we say is epilepsy, and the last thing we say is, well, what else could it be? And then we'll talk about the new 2017 International League Against Epilepsy classification system, which the American Epilepsy Society and other world epilepsy societies are adopting as they came together as a conglomerate to come up with these definitions. And then we'll talk about the anti-epileptic drugs. And this is a very difficult thing to talk about because you can get really scientific or stay really general, and I'm going to try and stay really general in talking about them. So first question is, why are descriptions of seizures so important? And so this first question with the audience response falls into that category. So you have an 18-year-old man who presents to this doctor saying he's been having these spells that began with an unpleasant sensation in his throat, followed by feeling a warmth around his mouth. Then he has dysarthric speech. And finally, he's hearing the sounds of whistling in his ears, and he has preserved awareness. So he can talk and interact normally during this spell, but it happens to him on a regular basis. So I put up here a picture of the brain, and it's multicolored, and we have around it different parts of the brain. And the question is, what part of the brain does this come from? And so you can answer your question now. So it's interesting. People say mesial temporal, parietal occipital junction. And so if you looked at the brain here as being your fist, the mesial temporal structures would be where my thumb is on the inside, and the parietal occipital junction would be here. Actually, this comes from the insula. So if I made a fist and I open the brain up and you see right inside the temporal lobe, it comes from the insula. And then it spreads to affect other parts of the brain. The reason why it's important to describe what you see and how it evolves or changes over time is it tells us where in the brain something comes from. So a frontal lobe seizure here would be hyperkinetic. A person has a lot of movement, and the movement's going to be probably discoordinated. You might have bicycling-like movements. You may have person sitting up and laying back down. A seizure starting here in the temporal lobe, mesial temporal lobe, may start with a well-defined aura or a bad smell. The occipital lobe seizures would start out with someone having a visual symptom, and of course motor or sensory would start out with a sensory phenomenon or a motor phenomenon. Next question is, we talk about drugs, and why do we have drugs, and how do the drugs work, and is there a reason on how certain drugs can work better than other drugs? So we talk about rational polypharmacy, which refers to the idea of combining two different anti-epileptic drugs together that have different mechanisms that may have a more potentiation effect or a synergistic effect in treating seizures. So the question is which drug-drug combination here provides the best in terms of rational polypharmacy? Oops. Interesting. So if we look at this, carbamazepam is a fast sodium channel. Lamictal works on sodium channels. Lacosamide and Lamictal are both sodium channels. One slow sodium channels, the other one's fast sodium channels. Lamictal may also work on T-type calcium channels. Tegretol, or oxcarbamazepam, and lamotrigine both work on sodium channels. Phenytoin and lamotrigine work both on sodium channels. Valproic acid and Lamictal, valproic acid works on T-type calcium channels, and lamotrigine works on sodium channels. And so the correct answer here is valproic acid and lamotrigine. So anti-epileptic drugs are known to cause birth defects. And so we shouldn't just throw these around to everybody. We should stop and think about a person's age before we start to use an anti-epileptic drug. And so which anti-epileptic drug is associated with cleft palate defects? Lamotrigine, Depakote, Topamax, or levetiracetam? And we say 93% Depakote. The actual answer is topiramate. And so a lot of people currently are placing women of childbearing age on topiramate for migraines. And they forget to ask themselves, what are the potential complications of using topiramate in a woman of childbearing age? And the big answer would be cleft palate defects. This next question is, which medicine is responsible for this birth defect? This is a neural tube defect, and these are your choices: lamotrigine, Depakote, levetiracetam, or lacosamide. And by far, everyone's aware of this, that Depakote, divalproic sodium, can cause neural tube defects. It occurs in approximately 1 in 5,000 live births. Now, it's really weird because I've never had a patient have a neural tube defect. And because I've never had it happen to me, I tend to use Depakote a lot. We know that folic acid, given prior to conception, helps prevent neural tube defects. Levetiracetam and lamotrigine are not associated or are at very low risk for causing birth defects. So with that, we'll go back and talk about seizures and epilepsy. And a seizure is defined as a clinical manifestation of an abnormal hypersynchronized discharge of a population of cortical neurons. So it's not subcortical neurons. It's not coming from the cerebellum. It's cortical neurons. And that group of cortical neurons can be what we call gray matter heterotopia, which is when the brain was formed, not all cells migrated where they were supposed to, and you may have a clump of cortex in the white matter where it shouldn't be. And then epilepsy is a tendency towards recurrent seizures that are unprovoked by some other systemic cause or neurological insult. So what are all the imitators of epilepsy? I'm not going to go through all of these, but you'll see list upon list upon list of various things that are oftentimes mistaken for being epilepsy. So the biggest one is someone has vasovagal syncope, or any type of a syncopal event where they drop their blood pressure, the brain doesn't get any juice. The longer that goes, the bigger the effect. Eventually someone has a tonic phase where they get really stiff and they fall down to the floor and they shake. Most often, if you have a vasovagal syncopal event, you will get pale and you may get clammy and sweaty. But a lot of people have syncopal events that are actually convulsive syncope events because they didn't lay down when they had the new onset of symptoms. People who have panic attacks may have hyperventilation, and hyperventilation can cause a seizure, dissociative episodes, and then you have fabricated and fictitious illnesses. And this is different from someone who has pure non-epileptic seizures who was suffering from post-traumatic stress disorder. So there are other imitators, sleep-related conditions, which we call parasomnias. Various types of movement disorders can also be can be epileptic in nature. Migraine-associated disorders can present as being seizures or ictophenomenon. And then you have this miscellaneous group of things here that can be associated with things that cause or look like seizures. And so it's important that we think about all that shakes is not epileptic. And medicines that we use to treat epilepsy can only treat epilepsy. They don't treat other conditions necessarily. And so this brings us to a classification of seizures, and why do we have a classification for seizures? So in the past, we've used words like complex partial seizures, simple partial seizures, secondary generalized seizures. And these terms are really bad terms because they don't tell us anything about the patient and the patient's conditions. And if you don't know much about the patient and the patient's conditions, you don't know what the best treatment options are for a particular patient. And so it's better nowadays, we think, to use common terms versus using vague terms and describe what you see. And so instead of calling a specific type of seizure, you describe what you see, because if you describe what you see, you're less apt to get confused by things that are epilepsy imitators versus things that are actually seizures. In addition to that, you're more apt to say what a neurologist likes to say is, where is the lesion? So when a person comes to see a neurologist, the first thing we really ask is not if it's a neurological problem. We say, where's the problem at? And if you know where the problem is, then you can develop a better differential diagnosis. For example, if someone presents as a child and they have spells where they just suddenly start laughing, ha 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 ha, and they do it repetitively, I'm going to say that kid probably has a hypothalamic hamartoma. Classic for kids, have laughing seizures, and they have a tumor in the hypothalamus. And so we would prefer nowadays for people to describe, using common language, what someone has doing an event versus saying a complex partial seizure or a simple partial seizure, because those are ambiguous terms that nobody really knows what they mean, such as absent seizure. An absent seizure or petit mal seizure just means small seizure. Is that someone staring for 5 seconds? Or is it someone who's just non-interactive for a period of time? And is that person always non-interactive? Or are they interactive because they're having a temper tantrum and they just don't want to react to somebody? And so with that in mind, we've decided to use terms such as focal onset seizures, generalized onset seizures, and unknown. You can determine if a type of clinical event is focal, generalized, based upon the presenting characteristics that a person describes a person does in terms of how it starts. When we think about it in that perspective, we can look at different types of seizures and say, is this due to structural, genetic, infectious, metabolic, immune, or is it an unknown etiology or cause? When we talk about genetic disorders, we really aren't necessarily talking about things that are genetic chromosomal, transferred down from family things, transferred from family to family, because a lot of things are spontaneous or de novo mutations. And so when we say genetic, you're including de novo mutations, not just familial things. And so from seizure types, we talk about epilepsy types. And one of the biggest problems we have with epilepsy types is that somebody could have a combined, someone can have a combined type, generalized, and focal. So we have people who present with focal seizures that are actually generalized, meaning they start from all over the brain at the same time. Or we have people who have generalized seizures, but they present as focal seizures. And so it's better to use terms and descriptors because now you can better put people into those terms. From epilepsy types, we can go into epilepsy syndromes based upon different things that go along with each other, such as Lennox-Gastaut syndrome, which is characterized by slow spike and wave on an EEG, cognitive impairment, and multiple seizure types. And then when people have epilepsy types or syndromes, they often will have comorbidities. So intellectual disabilities can occur with people with epilepsy due to the epilepsy syndrome or epilepsy encephalopathy that occurs. So if we look at generalized epilepsies, it's interesting. We used to think that a generalized seizure start from some subcortical place and then spread from that through the rest of the brain. But actually, they develop from subcortical networks. So it's a network of different cells that fire and are interconnected through various connections. And knowing how those pathways interconnect helps us determine epilepsy. It's not just one deep place. It could be all over the brain, but it's the way the network is set up. And so you can have a yo-yo effect where this site is reversing from point A to point B, and you get this cyclic figure 8 matter, and that causes a seizure. It's going back and forth or oscillating. Or you can have complex subcortical networks that interact on both sides of the brain. And if you did a PET scan on someone, you would see different networks involved at the onset of a seizure, depending upon when you gave your tracer. Likewise, with focal seizures, they would start with a focal network. They'd start at point A and then spread discretely to another part of the brain. We call temporal lobe seizures. Oftentimes people will have seizures, and on their EEG we'll see bilateral temporal spikes, but all their seizures come from onset from the left temporal lobe or from the right temporal lobe. There may be some interconnecting network of cells where the seizure actually starts in a deep focus on the left temporal lobe and then immediately spread to the right, and you get fooled by saying this seizure starting on the right, but in reality it's starting on the left from a deep focus. We define this based upon the clinical description of the seizures and then by placing depth electrodes into the brain and picking up seizure foci. So with that, we talk about the 2017 classification of seizures types, an expanded version. And using this expanded version, we again focus on focal onset seizures or localized related seizures. And we talk about, is awareness maintained? Can I talk and interact with you in a normal way? Or is there an altered awareness? So it's interesting that we look at it from this perspective. If you look at the DOT, it says if you have an episode of altered awareness or loss of consciousness, regardless as to cause, you can't drive for 60 months. The key word that they use there is altered awareness. But if you're having focal seizures and you're aware of what's going on, in theory, you could still drive even though you have epilepsy. I have problems with that concept because you don't know when it's going to spread and become a larger type of an event, and you do have an altered awareness. if you look at these lists, you'll see that atonic seizures are in focal onset seizures, but atonic seizures are also in generalized onset seizures. So if we were to go back, and I took a board exam in epilepsy 2 years ago, and the test question said, what kind of seizure is this, focal or generalized? And the answers had an atonic seizure in it. I'd have to say atonic seizures are generalized. But in reality, an atonic seizure can come from a deep focal frontal focus and spread rapidly and make someone collapse, and it would be focal onset. You have non-motor focal onset seizures, and then you have your generalized onset, motor, and non-motor. The non-motor are classically absent seizures where you have that brief, less than 15-second period where you stop and you just stare off. Your eyes may flutter back and forth, what we call eyelid myoclonia. And these typically will have a generalized spike and slow wave discharge at their onset. And then unfortunately, we always have these unknown onsets and things that we can't classify. But we'd like to have people use these terms versus the older traditional terms because it allows us to better determine what a person has. So the terms complex partial, simple partial, partial, psychic, dyscognitive. Dyscognitive was a term that came out in like 2000, let's say 10, classification where someone had altered cognitive impairments. But using awareness is better understandable by common people. So that brings us to anti-epileptic drugs. And an anti-epileptic drug is a medicine that decreases the frequency or severity of seizures in people with epilepsy. They treat symptoms of seizures, but not the cause of seizures. And they do it by either blocking excitation or enhancing inhibition. Anti-epileptic drugs do not stop the development of a seizure focus. They just slow it down or prevent this focus from taken away. The goal of therapy is not necessarily to stop all seizures, but the goal of therapy is reduce the number of seizures, have no adverse drug effects, and improve one's quality of life. So these are all the anti-epileptic drugs we have starting from 1857 to present. There are probably right now another 10 drugs that are being looked at very closely in phase 1 and phase 2 trials to treat epilepsy, one of which would be cannabidiol. We're involved in a cannabidiol study here. What we have found to date when I was at the AES meeting in DC in December is that 40% of the people do really well. 40% of the people, it does nothing. 20% of the people, we see a gray zone. It's kind of hit and miss. So it's not the panacea that people talk about. Other things we see about cannabidiol is it is an inhibitor of metabolism. So people who are on benzodiazepams that may have a normal half-life of 6 hours, that half-life now may be increased to 18 hours. And so we'll have people who have had basic routine anesthesia, who have fallen asleep, and they don't wake up for 3 days. We see people with elevated liver function tests. In most cases, these have dropped. And in some cases, it actually has aggravated the number of seizures that a person may have. When we look at these anti-epileptic drugs by year, we talk about first-generation drugs, 1857 to 1978. If we look at this list, the only legitimate anti-epileptic drugs that we had was phenobarbital, phenytoin, carbamazepam, and valproic acid. All the other ones that are listed here are relatively minor anticonvulsants. Second generations are those from 1993 to 2005. It's interesting that felbamate that came out in 1993 was a fantastic drug. We all liked it, and we were all excited about using it. It's a very potent drug. And after it was on the market for 2 years, 27 people died. The company did not take it off the market, and the FDA did not require them to take it off the market, but they kind of suggested that people kind of stop using it, and it got this big black box warning saying it can cause aplastic anemia and bone marrow failure and liver failure. Now, if you look at the 27 people that all died when they were on felbamate, they all had other underlying severe medical problems to begin with. Now, what's interesting here is that you have idiosyncratic reactions to some of these medications. And so I'll talk about Lamotrigine. And I'm going to talk about Lamotrigine because this was one of these other God gifts to man as well. I had a young lady who we put on Lamotrigine who developed pancytopenia and idiopathic intracranial hypertension. And Dr. Ottoman, I don't know if you remember that little girl, helped us diagnose that as a problem. We took away the Lamotrigine, and she went away, and she got better, and her pseudotumor went away. And interesting, but it's a one-time thing that happened. And so when we use these meds, we have what we call idiosyncratic reactions that occur. Third-generation anti-epileptic medications, lacosamide, rufinamide, vigabatrin, perampanel, eslicarbazepam, and Breviact. So most of the people in this room have probably heard of lacosamide, but not the other meds. So vigabatrin actually has been around since the early 70s. It causes concentric visual loss, and so it was noted by a optometrist in England who was placed on the drug. After he was on it for about a year, he started having problems with his vision, and he went to the company and said, "Your drug is causing me to have visual loss," and he had concentral visual loss. And everybody laughed at him, and then all of a sudden, about 5 years later, a lot of people start coming up with the same problem. And so it affects the optic chiasm, and we don't really understand why or how it does it. It wasn't approved in the U.S., and we thought it would never get approved in the U.S., but it did get approved in the U.S. About 2009, and it's very restricted medicine, and you have to have eye visits on a regular basis to get it. Now, there's another drug I took off my list called Exagabine, which would have came out in 2014, down in here, that was approved, and it makes people turn blue. It was released because very few people used it. The company this year decided to withdraw it back from the market. And so there's very few medicines that really come out to treat epilepsy and other conditions because drug trials and drug studies are so rigorous that you spend millions and millions of dollars on the drug study, and then if you have one med that flops or fails, as a company you've invested all that money, you don't have any way of recuperating it. So that's why meds cost so much money, and why some of the generics still cost a lot of money because companies have to recoup the gains that they lost. The newer meds that have come out in the last 10 years are more water soluble. They have fewer, in theory, adverse drug effects, but some of them are still Me Too drugs. And when I talk about Me Too drugs, the prime example is carbamazepam, its cousin, oxcarbamazepam, and its cousin, eslicarbazepam. So they're all fall in the same family. Each one of them have a different isomer. So try oxcarbazepam here is an isomer of carbamazepam, and then eslicarbazepam is another isomer, and this has the least metabolism of all of them. If you were to look at the drug studies on people that they placed on eslicarbazepam, there was a 20% reduction in seizures in people who had already been on the other two meds in the same family, but they still work the same way. I call them Me Too drugs. They cost a lot more money. What's nice is eslicarbazepam is given once a day. Trileptal, oxcarbazepam is still twice a day. Carbamazepam technically is a 3 times a day medication based upon its half-life. Most of us use it twice a day, but the companies come out with extended release medications, and the extended release medications for oxcarbazepam is still a twice a day medication. it really serves no advantage over the once-a-day prep in most cases. Levetiracetam has a half-life of 12 hours, so it should be given twice a day. In order to extend its patent, the company came out with Keppra XR to extend its patent, but they didn't tell us that the CNS half-life of levetiracetam is like 32 to 36 hours. So because the CNS half-life is so long, you can actually give levetiracetam once a day. So with that, I guess I should move on. So we talk about anti-epileptic drugs and seizure types. So the biggest reason to classify seizures into different types is that we have different models of epilepsy. And using different models for epilepsy, and that's how we test the meds, we find out that certain models, certain drugs will work better in that model than in other models. So now you're at a point to where you can create a silver bullet to treat a specific type of epilepsy. So if you look at absence epilepsy, acetazolamide, clonazepam, valproic acid, S-suxamide, lamotrigine, and methoxamide, they all have similar actions in some degree, and so they're great for treating absence seizures. The idea here is that if you don't know what type of seizure someone has, you can make a good educated guess to say, I'm going to use this medicine for this person, because if you use medicine Y, so if you use Tegretol to treat absence seizures, it'll make it worse. Carbamazepam will also make myoclonic epilepsy worse. So we know that. And so knowing the descriptions of seizures, not saying complex partial or simple partial, but actually having the description, oh, I have these body jerks, and they only happen when I go to bed at night and I fall asleep. Well, that sounds more like JME or juvenile myoclonic epilepsy, so you're going to not use Tegretol and other medicines known to make that type of epilepsy worse. Seizure clusters, so clobazam is a benzodiazepam that's very long-acting that works very well to prevent people from having seizure clusters. It got approved within the last 5 years. So interesting, we see acetazolamide up here as episodic disorders. Acetazolamide, we don't understand and we don't know why, is very useful in treating catamenial epilepsy. So women around who have menstrual-related epilepsy or seizures, that helps prevent them from having seizures around that time. I've never had a good, I can't say I've had anyone who truly had catamenial epilepsy that it's been effective in. So localization or focal onset seizures, nearly every med that we have on the market will treat this type of epilepsy, except ethosuximide. Ethosuximide or Xarelto only treats absence seizures, 3 hertz spike and slow wave. Localized onset seizures, we don't say secondary generalized anymore. We say with bilateral tonic-clonic seizures. So focal seizures become generalized seizures. We don't say secondary generalized anymore because these networks of cells, not knowing how they network together, they may be generalized from onset, but you don't see it clinically because the amount of the brain is not involved. Then we have these epileptic syndromes. The International League Against Epilepsy classification for 2017 does not include syndromic classification in the new classification system, but we do have these epileptic syndromes. Stiripentol is not available in the U.S., but it's probably the best drug to treat Dravet syndrome or severe myoclonic epilepsy in infancy. Lennox-Gastaut syndrome, we talked about it earlier. It's only, refinamide is only approved to treat that as a syndrome. However, if you say a person has Lennox-Gastaut syndrome-like, and you say they have cognitive impairment, and they have mixed seizure types, and you don't have the slow spike and wave EEG, you can get it approved by Medicaid and Medicare to treat other types of epilepsy where people don't have Lennox-Gastaut syndrome. So these just goes through, the next slides really basically go through and talk about different seizure types and meds that are used to treat them. I did not put in slides that said these meds will make this condition worse, but more a matter of saying that we now are at a point in epilepsy and epilepsy treatment that if you know enough about the disease state or the type of seizures, you can figure out better drugs to treat the patient up front than at the back door. So currently, this has not changed, even for new meds coming out on the market. Brown and Brody did a study out of Scotland that said the first drug I pick, doesn't matter what it is, if I give it to you, 1/3 of patients will be seizure-free. If I go back to my shelf and take another drug off, another 14% of patients will be seizure-free, or 47%. Of those that are still having seizures at 53%, I go back to my shelf, take off another drug, and hand it out. 63 to 66% of people will be seizure-free. So currently, 1/3 of all patients with epilepsy still will have refractory seizures, regardless of what we do in terms of medical therapy. If we were to look at new drugs coming on the market, they may improve that by 8%. So those patients that are left, we would do epilepsy surgery on, 12%. And so you're left with 8 to 10% of patients with epilepsy who will always have refractory seizures. Most of my patients currently that I have in my clinic are refractory epilepsy patients. I don't have very many easy-to-treat epilepsy patients. And so that brings us to mechanisms of action. And this was a really hard thing for me to decide whether or not to put into the talk or not to put into the talk, because everything nowadays is looked at mechanism of action. And to be totally honest with you, we don't know how these drugs work. We have assumptions and theories by various different types of models, but we don't really know how they work. Most of the meds that we use work on sodium channels by blocking sodium channels and on calcium channels. The newer meds that we have coming out nowadays are working on NMDA receptors and glutamate receptors. So you have these two systems, GABA, which is inhibitory, and glutamate, which is excitatory. And most of the meds we work on either enhancing GABA or inhibiting glutamate. I'm going to skip through these. So if you look at a receptor, a GABA receptor or GABA channel, they're really sodium channels. And we have meds that work on inhibiting the sodium channel. So your benzodiazepines act at this site, barbiturates act here, steroids, so we see, I didn't have ACTH up in my list, I don't think, of meds, but we use it a lot to treat kids who have different types of epilepsy, as in other disorders. Picrotoxin is a model that we use to create epilepsy syndromes in the lab and test anticonvulsants to see on how well they are at treating picrotoxin-induced epilepsy. I'm going to skip through these. So if you look at the glutamate receptors, there's two types of glutamate receptors. There's the AMPA receptor, which is here, and then there's the NMDA receptor, and then there's a cannate receptor, and I'm blocking on where it is. It's not shown on here. But those are all stimulants or excitatory. And so I'm going to go back to this picture of the brain, and I'm going to say that, again, to summarize things, is that we use anticonvulsants to treat seizures. We don't know where seizures come from by using vague terms such as complex partial or simple partial. We would rather have people describe what they see in simple, normal language, layperson's language. From there, we can make an educated guess on where in the brain a seizure focus may come from and determine if it's generalized or focal. And based upon that, we can better design drugs to treat epilepsy. The rest of these slides actually talk about pharmacokinetics and elimination half-lives of drugs, and I'm not going to bore you with going through that, and I'll stop there and answer any questions if people have questions. or comments? Yes, Dr. Kitchell.
Obviously, David, you and I see a different type of patient. Most of my patients are easily controlled because when they're not easily controlled, I refer them to you. But going back to the percentages that you gave for people that are likely to be controlled with one or two of the medicines versus patients, 12% of them might need epilepsy surgery. How do you decide, or when do you decide that they are, obviously they have to have a localizable lesion, but how do you decide when to send them for epilepsy surgery?
So Dr. Kitchell asks actually two questions. One is, when is a person considered refractory? And so if you fail 2 drugs, you have refractory epilepsy. And at that point, you can say that a person is a candidate for epilepsy surgery. So if you fail 2 drugs, you can say a person is a candidate. In order to maintain being a candidate for epilepsy surgery, you have to have a focus or a localized place where seizures come from, and that focus cannot be in what we call eloquent cortex. So if we remove that part of your brain, you still have to have good function, and it can't alter who you are. So the process that we do to evaluate patients in that sense is we do basic inpatient hospital monitoring, which we do here in our hospital. We do monitoring of patients with epilepsy and find out if you have one focus or more. In the picture that I showed, it's really hard nowadays to determine sometimes if a person has a single focus or if they have 2 foci, but because they have this mirror image, it appears that the seizures come from this other focus, but in reality it's the other focus. So the process is you admit patient, remove their drugs, capture seizures, and you compare electrographically and clinically what the seizure looks like. And if you have a focus that's easy to get to, or you have a lesion on your MRI, those patients are eligible for epilepsy surgery. We're now doing, for epilepsy surgery, high beam focus radiation therapy or laser therapy to burn an area of the seizure focus versus actually doing a craniotomy and removing the focus. Other questions? And I thank you and have a very Merry Christmas all.